Hi all. Today we are going to discuss about lung volumes and capacities and also about surfactant. I am Dr. Subhashri, Associate Professor of Physiology in Sri Lakshmi Narayana Institute of Medical Sciences. So we move on to the topic. So first, it is about the lung volumes and capacities. So physiologically, lung volumes and capacities are classified as there are four lung volumes and there are four lung capacities. So what are the four lung volumes? We have tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. And we have four lung capacities. They are total lung capacity, vital capacity, functional residual capacity, and inspiratory capacity. So here we'll be seeing one by one. So the first thing that we are going to see is about the tidal volume. It is about the lung volume. The first of all lung volume is the tidal volume. So what is tidal volume? Tidal volume is the volume of gas that are inspired or expired during a quiet breathing. So at rest, how much amount of air we inspire and how much amount of we expire will come under tidal volume. The normal value of tidal volume is around 500 ml. So the next volume is inspiratory reserve volume. So the name itself says here, it is the inspiratory. That means the amount of air that is inspired. And reserve. What do you all mean by reserve? Reserve is something extra to the normal, right? So what is inspiratory reserve volume? It is after a tidal inspiration. That is at rest we are inspiring, right? So from that point, after the tidal inspiration, how much amount of air that can be maximally inspired? Okay, shall I say it in another way? That is, it is the amount of air inspired in excess to the normal tidal inspiration. Okay, so the normal value is usually volumes and capacities will be little higher in males because of their build and little less in females. So the inspiratory reserve volume in male is 3.3 liters and in women it is 1.9 liters. The third volume is expiratory reserve volume. Same as inspiratory, but here it is the amount of air expired. That is after a tidal expiration. Okay, at the end of tidal expiration, the amount of air that is expired in excess. Shall I explain it in another way? That is, it is the volume of air expired in addition to tidal expiration. Okay, so after a normal expiration, from this point, it is the volume of air in excess that is expired. Okay, so here also in men it is around 1.2 liters, whereas in women it is 0.7 liters. The fourth volume is residual volume. So what is residual volume? Residual, the name says residual is which is remaining, right? So what is residual volume? It is the amount of air remaining in the lungs. It is not the air that is coming out. Rather, it is the air that is remaining in the lungs after a maximum expiration. So all of you expire maximally. After a maximum expiration, there will be a little amount of air still remaining in the lungs. That is called as residual volume. So these are the four volumes. So what are the four volumes? We have tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So what is tidal volume? Tidal volume is at rest how much amount of air that can be inspired or expired. What is inspiratory reserve volume? It is the volume of air inspired in addition to tidal inspiration. The same way is expiratory reserve volume. It is the amount of air expired in addition to tidal expiration. And last is residual volume. It is the amount of air remaining in the lungs after a maximum expiration. Okay, so these are the 4 lung volumes. Next, moving on to the lung capacities. So usually capacities are addition of 2 or 3 lung volumes. So we have 4 lung capacity. The first is vital capacity. So vital capacity is defined as, like, all of you, like, take a deep inspiration to the maximum. Okay, so after a deep inspiration, our lungs will accommodate the maximum amount of air. From that point, you have to expire forcefully. Okay, maximally and forcefully. So amount of air that is expired maximally or after a deep inspiration is called vital capacity. Okay, so next is inspiratory capacity. Before only I said any capacity will be addition of 2 or 3 lung volumes, right? So what is inspiratory capacity? Capacity is the amount that can be held, right? So how much amount of air our lungs can hold during maximum inspiration. Okay, so it is the addition of tidal volume plus inspiratory reserve volume. Okay, so it is the maximum volume of air that can be inspired after a tidal expiration. Okay, third capacity is functional residual capacity. Residual, before only we have seen, it is residual volume. Usually you will get confused with residual volume and functional residual capacity. Here, it is also residual, that is remaining air only, but little different. That is, functional residual capacity is the volume of air remaining in the lungs after a tidal expiration. Let me explain residual volume again. Residual volume is the amount of air that is remaining in the lungs after a maximum expiration. Whereas functional residual capacity is the volume of air remaining in the lungs after a tidal expiration. Okay. So here it is around 2.2 to 2.5 liters. Functional residual capacity is addition of 2 volumes: expiratory reserve volume and residual volume. Okay. The last lung capacity is very easy, which is the total lung capacity. So what is the total lung capacity? The amount of air that is present in the lungs at the end of maximum inspiration. So after maximum inspiration, how much amount of air can remain in the lungs is called total lung capacity. The total lung capacity in males is 6 liters and females is 4.2 liters. So these are the lung volumes and capacities. So there are 4 lung volumes and 4 lung capacities. So how can this lung volumes and capacities be measured? Usually, the lung volumes and capacities are measured directly by a simple spirometry. Okay. The next picture, in the next slide, we have the spirometry recording, where with a simple spirometry, we can record the lung volumes and capacities, except for 3 lung volumes and capacities that cannot be measured with spirometry. They are residual volume, functional residual capacity, and total lung capacity. So these are the 3 volumes and capacities that cannot be measured with spirometry. So what is used, or what technique is used to measure this is, this can be measured indirectly using a technique called dilution technique. Here it is exactly, if you want me to say, it is helium dilution technique. So helium dilution technique is used to measure residual volume and functional residual capacity which cannot be measured with spirometry. So this picture shows the recording of spirometry, where here if you see from 2500 to 3000, which is around 500 ml, is tidal volume. So what is tidal volume? Let me repeat again. It is the amount of air that is inspired or the amount of air that is expired during rest. At rest, the amount of air that is inspired or the amount of air that is expired is called tidal volume, which is around how much ml? 500 ml. Okay. The second volume is inspiratory reserve volume. So what is inspiratory reserve volume? You will ask your subject to do a tidal inspiration, tidal expiration, and you asked to do a tidal inspiration. From this point, after tidal inspiration, the amount of air that can be inspired maximally. So this blue color is inspiratory reserve volume. Okay. The third volume is expiratory reserve volume. So what is expiratory reserve volume? The subject will take a tidal inspiration and tidal expiration. At the end of tidal expiration, you ask them to stop. From this point, you ask your subject to expire maximally. This excess amount of air that is expired out after tidal expiration is called expiratory reserve volume. Okay. The fourth volume is residual volume. So what is residual volume? Residual volume is after maximum expiration. So only this much the person can expire. After that, he cannot expire extra. So after a tidal expiration, there will be a little amount of air still be remaining in the lungs. Our lungs will not get emptied out fully. So that remaining amount of air which is present inside the lungs after a tidal expiration is called residual volume. So these are the four lung volumes and four lung volumes. Let me discuss about the lung capacities. So we have four capacities. First is inspiratory capacity. So what is inspiratory capacity? It is addition of tidal volume plus inspiratory reserve volume. So it is from tidal expiration, the person will inspire. Initially, he will be inspiring tidal volume. After that, he will be inspiring inspiratory reserve volume. So if you add these two, you will get inspiratory capacity. Okay. Next capacity is functional residual capacity, where you will ask your subject to do a tidal expiration. At the end of after the tidal expiration, it is the amount of air remaining in the lungs. So this entire thing is called functional residual capacity. Okay. Third capacity is vital capacity. So what is vital capacity? You will ask your subject to take a from deep inspiration. From this point, you will ask to expire maximally. So this big line is called vital capacity. Last is total lung capacity. What is total lung capacity? From 0 till maximum. So it will be addition of residual volume, expiratory reserve volume, tidal volume, inspiratory reserve volume. So if you add all the volumes, it will be total lung capacity. It can also be said as addition of functional residual capacity plus inspiratory capacity. Okay, so these are the lung volumes and capacities. So next, so this is about the lung volumes and capacities. Okay, so the first topic we have discussed, which is about the lung volumes and capacities. I'll repeat it again. We have total of 4 lung volumes and 4 lung capacities, which can be measured with spirometry. The spirometry recording also we have seen. The 2 lung capacities, actually, in fact, it is 3. One is residual volume, functional residual capacity, and total lung capacity cannot be measured with the spirometry. Rather, we'll be using a helium dilution technique for recording the 3. Okay, so the second topic of discussion is surfactant. So what is surfactant? Before moving on to the topic surfactant, we need to understand the basic concept. Okay, so what is surfactant or what is surface tension? We'll be learning now, which is the basic concept to understand surfactant. Okay, so how are the raindrops formed? So actually, how is a water drop formed is whenever water molecules and air come in contact with one another. Okay, so whenever water comes in contact with air, the water molecules will try to come together because of a presence of a tension called surface tension. Okay, so what happens is all the water molecules will come closer and form a drop. This holds the raindrop together. Okay, so this water molecule are attracted towards one another because of a tension called surface tension. So when surface tension will be present is whenever water comes in contact with air. Okay, so what happens whenever water comes in contact with air? The water molecule present in that area will try to come closer or will try to or get attracted towards one another because of surface tension. Okay, so that is what I have said in this slide. So when water forms a surface with air, the water molecules on the surface have a special strong attraction to one another. Okay, so what happens as a result? The water surface tries to contract. This holds the raindrop. Okay, so imagine in our lungs we have alveoli. Alveoli inner surface is lined with a thin layer of water, whereas air will be moving in and out from our environment. So what happens in our alveoli inner surfaces? There also there is a interaction between water and air, right? So what happens in the alveoli here? The water molecules come in contact with the air. Just before I said, whenever water comes in contact with the air, because of surface tension, the water molecules tries to come closer. So same thing happens in the alveoli. So the water surface, the thin water surface inside the alveoli will try to come closer. So this is the alveoli and we have a thin layer of water here and air is coming in. Okay. So what happens? Because of surface tension, the water molecules in the alveoli will try to come closer. So whenever water molecules are trying to come closer, the alveoli will try to collapse. Right? So is that happening in our lungs? Will the alveoli collapse in our lungs normally in a healthy individual? No, because the surface tension created by the air and water interface is reduced by a agent called surfactant. Okay, so what is happening? So this is, imagine this is our alveoli. The inner surface of the alveoli is lined with a thin layer of water. So we have air coming in to the alveoli from our environment. So what happens here? There is air and water interface. Whenever air comes in contact with water, there will be a tension created here called surface tension. And this surface tension will try to bring closer the water molecules. So whenever water molecules around here try to come closer, the alveoli will also try to collapse. But this does not happen in our lungs normally because of the presence of surfactant. So what is a surfactant here? Surfactant is a surface active agent in water, which will try to reduce the surface tension. Okay, so this surfactant is inversely proportional to surface tension. That means whenever surfactant is more, surface tension will be less, and whenever surfactant is less, surface tension will be more. So what are surfactant? Finally, they are surface active agents which will try to reduce the surface tension. Okay, so what is the source of surfactant? So surfactant in our alveoli are synthesized from type 2 pneumocytes. So what are type 2 pneumocytes? When you see this picture, this is the alveoli. Okay, so this is the alveolar membrane. So this is the alveolar membrane. This is the alveolar lumen, and these are the alveolar cells. So this is type 1 pneumocyte and this is type 2 pneumocyte. So from this type 2 pneumocytes, which are secreted, the surfactant are secreted, and they will go and line the inner surface of the alveoli along with the water molecules. So what are present in this surfactant? Surfactant has 90% lipids. Of the lipid, 62% are by DPPC. What is DPPC? Dipalmitoyl phosphatidyl choline, which is otherwise called dipalmitoyl lecithin. Okay, so it is dipalmitoyl phosphatidyl choline or dipalmitoyl lecithin, which is around 62% of the surfactant. Then we have phosphatidyl glycerol, other phospholipids and neutral lipids, which contribute very less. Remaining 8% of surfactant is by proteins like albumin, IgA, and apoproteins, and 2% is by carbohydrates. So surfactants are mainly made up of lipids. So how will a surfactant be? It has a hydrophilic head and a hydrophobic tail. The hydrophobic tail will be towards the alveolar lumen. We have a hydrophilic head which will be towards the pneumocytes. So this is the shape of this is the presence of surfactant in our alveolar lumen. Okay. So next to composition, we'll be seeing about the steps of synthesis. How are surfactants synthesized? So surfactants are synthesized, so as I have already said, it is from the type 2 pneumocytes. So what will this type 2 pneumocytes do is, they will take up the substrate molecules like palmitate, choline, glucose into it from the blood. Inside the type 2 pneumocytes, the substrate molecules synthesize the DPPC, which is the main lipid of surfactant. But what is DPPC? Dipalmitoyl phosphatidyl choline, which is synthesized in the mitochondria. The type 2 pneumocytes have endoplasmic reticulum, which will produce the protein components of the surfactant. So what will happen? So this DPPC and the protein components, the DPPC from the mitochondria and the protein components from the endoplasmic reticulum are together packed in the Golgi apparatus. So in the Golgi apparatus, these are packed and stored as lamellar bodies. Whenever needed, these lamellar bodies are secreted to the alveolar surface by the process of exocytosis. These lamellar bodies in the alveolar lumen will get converted into a myelin called tubular myelin. This tubular myelin forms a thin layer on the inner surface of the alveoli, which acts as the surfactant to reduce the surface tension. So this is the steps of synthesis of surfactant. So when surfactant gets synthesized this starts getting synthesized in our fetal life. That is whenever we are in the intrauterine life only, this gets started synthesizing. But later part of pregnancy, but during the later part of pregnancy at around 34 weeks, and the surfactant synthesis gets completed at around 38 to 40 weeks. That is around 90% at the term. Okay, so what are the regulation of surfactant? We have four main regulators. One is hormonal, stretching of lungs, any pharmacological agents or exercise. So hormones like glucocorticoids, thyroxine and insulin will increase the surfactant secretion. Stretching of lungs during yawning or any pranayama exercise will increase surfactant secretion. Pharmacological drugs like beta adrenergics and calcium will increase um, surfactant secretion. And exercise, regular physical exercise will also increase surfactant secretion. So these are the regulators. So far, what all we have seen? So what is surface tension we saw? What is surfactant and its definition? Then we saw what is the source of surfactant, which is the type 2 pneumocytes. Then we saw about the composition of surfactant. Then we saw about the steps of synthesis. And now we have seen about the regulation of secretion and synthesis. So the next thing that we are going to see about the surfactant is what are its function, which is a very important concept to be understood. Okay. So the first and foremost function of surfactant is it promotes alveolar stability. Okay, so that is in the first only we saw. Whenever water and air molecule comes together, what will happen? The alveoli will try to collapse. But presence of surfactant will reduce the surface tension, thereby promoting alveolar stability. To understand this concept of alveolar stability, we need to know a law called Laplace law. What is Laplace law? Laplace law states that pressure is equal to 2T by R. T is the tension and R is the radius. Any hollow viscous in our body, like urinary bladder, alveoli, will follow Laplace law. What is Laplace law? P is equal to 2T by R. Since alveoli is a hollow organ, or a hollow structure, it has a lumen inside it. It follows Laplace law. So understanding Laplace law is very important to understand the concept of alveolar stability. Okay, so how surfactant will produce alveolar stability is, see, imagine in our lungs are lungs have alveoli fully, right? But the size of the alveoli are not same everywhere. In some part of our lungs, our alveoli are bigger, whereas in some part of our lungs, our alveoli are smaller, but all are connected to one another, right? So imagine this is a bigger alveoli at one part of the lung, and this is another small alveoli in another part of the lung, and they are all connected to one another. Okay, so what happens if surfactant is not there is the bigger alveoli radius will be more. Because of bigger radius, there will be more amount of water molecules here. So what will happen to the tension here? It will be more. Based on the Laplace law, pressure is equal to 2T by R. So it is around 2. The pressure generated in the bigger alveoli will be 2. Imagine the smaller alveoli is also having the same tension. What will happen there? The smaller alveoli radius will be less, whereas this is a hypothetical question. So what happens if the tension is same in all the alveoli? So what happens in a smaller alveoli with small radius and same tension as that of the bigger one? Based on the Laplace law, according to the Laplace law, the pressure generated here will be 4, which is higher than the pressure of the bigger alveoli. Okay. So what is the pressure here? It is 2. What is the pressure here? It is 4. Always air try to move from higher pressure to the lower pressure area. So what happens here? The air will try to move from the higher pressure area, which is the small alveoli, to the lower pressure area, which is the big alveoli. So what can happen here? The small radius alveoli will try to collapse, whereas the big radius alveoli will try to distend. If this happens, there cannot be a normal gas exchange that can take place in our lungs. So what is there? This will not happen. Rather, our alveoli have surfactant. So the bigger alveoli will be having more surfactant. The smaller alveoli will be having less surfactant. In the first slide only I said presence of surfactant is inversely related to the tension developed. So what will happen in the bigger alveoli? Because of more surfactant, the tension developed here will be less. So radius 10, tension 10, what will be the pressure according to Laplace law? It will be 2. Whereas in smaller alveoli, the tension will be less. So what will happen? Radius 5, the tension will also be 5. So according to Laplace law, the pressure created will be 2. So the pressure here is also 2 and the pressure in the smaller alveoli is also 2. So will there be any movement of air? No. So thereby preventing the alveoli to collapse or alveoli to distend. So this surfactant will maintain the alveolar stability. So how it promotes alveolar stability? In lungs, the alveoli are of different diameters and they are connected to one another. Okay. So according to Laplace law, smaller alveoli can drain into the larger one and collapse. But this does not happen because of the presence of surfactant. So what is surfactant? Surfactant is constant per unit surface area. So does surface tension. So this surfactant will achieve this by lowering the surface tension proportionately more in smaller area. That is, the tension developed in the smaller will become, it will reduce the surface tension in the smaller alveoli, thereby maintaining the pressure same as that of the larger alveoli also. Okay. The first function of surfactant is it promotes alveolar stability. The second function is it promotes lung collapse. How it promotes lung collapse? Just now we discussed. This decreases the surface tension at the air-liquid interface. That by decreasing the surface tension, it prevents lung collapse. Okay. The third function is surfactant also prevents pulmonary edema. Okay. How it prevents pulmonary edema is this surface tension. Because of the surface tension, what happens is there will be an inward force into the alveoli. Okay. So this inward force in the alveoli will usually pulls the fluid from the capillaries into the alveoli. So what can happen? Alveoli can be filled with fluid, right? So this is called pulmonary edema. But because of the presence of surfactant, the surface tension will reduce. So this reduced surface tension cannot pull the fluid from the capillaries. So fluid will not move from the capillaries into the alveoli, finally preventing pulmonary edema formation. Okay. Next function is it decreases the work of breathing so that breathing becomes easier. Next and last function is it has a function on immunity. In the composition only I said surfactant has immunoglobulins and apoproteins which will provide innate immunity, and also it promotes phagocytosis by alveolar macrophages to kill any bacteria or virus entering into our lungs. So these are the functions of surfactant. The last that we are going to see as usual is the applied aspect. So applied aspect, what is the importance of surfactant and what happens if surfactant is not present is usual condition is called infant respiratory distress syndrome. Okay. So what is infant respiratory distress syndrome is? What is the point where surfactant gets synthesized first is around 34 weeks. I said no, during the later part of pregnancy only surfactant will get synthesized. So imagine a child is a premature child. It is born even before 34 weeks. So what happens? There will not be any surfactant in the lungs of the child, the premature child. Only if surfactant is there, it prevents the lung collapse. Right? So in a premature child, because of no surfactant or because of very less surfactant, the alveolar stability cannot be maintained or alveolar collapse cannot be prevented. So what happens in that child? The alveoli will tend to collapse. So here and there will be atelectasis, because of which gas exchange cannot take place. So the child will have respiratory distress or the infant will have respiratory distress. So this is called infant respiratory distress syndrome. So after birth, the newborn makes a strong inspiratory effort so that the lung expand. When surfactant is there, after expansion, this will prevent the collapse of the lung. But in an immature lung or in a premature infant, because of the lack of surfactant, the lung cannot be maintained in an expanded state. Rather, the lung will collapse. So this makes the child to have respiratory distress. So this is called infant respiratory distress syndrome. So what is the treatment of infant respiratory distress syndrome? Usually we can administer phospholipids by inhalation. As we said, lipids are the main composition of surfactant. We can give synthetic surfactants to the child also, and we can give glucocorticoid therapy to the child. Glucocorticoids will increase the surfactant synthesis. If it is an elective premature delivery, we can even give glucocorticoids to the pregnant mother so that can increase the surfactant synthesis to the child which is present inside the uterus, thereby preventing infant respiratory distress syndrome. So this is about the clinical importance of surfactant. So thank you. So this class we discussed about the lung volumes and capacities and also about the surfactant. Thank you.